Good afternoon, everybody, and thank you for joining us for today's nicotine replacement therapy webinar. I'd like to make an acknowledgement of country before we get started. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'd like to introduce our presenters for today's webinar. We're joined by Dr. Rowena Ivers and Ray Collins. So Associate Professor Rowena Ivers is an academic GP who has worked in Aboriginal community-controlled health services for over 20 years. She has an interest in tobacco control and has been involved in a number of projects to reduce the harm resulting from tobacco. Rowena is joined by Ray Collins, who is a drug and alcohol worker with the Illawarra Aboriginal Medical Service. So thank you for joining us, Rowena and Ray.
Thank you.
Thank you.
No worries. I'll hand over now to Rowena. We'll take you through the learning outcomes and jump into the presentation.
Oh, actually, the learning outcomes for this webinar today, by the end of this online QA and CPD activity, you should be able to analyse management and intervention strategies when using NRT, discuss the barriers to optimal smoking cessation strategies faced by Aboriginal and Torres Strait Islander people, identify specific advice and referral services that can assist clients at your Aboriginal community-controlled health services, and recognise how the National Guide to the Preventive Health Check for Aboriginal and Torres Strait Islander people can support best practice in prevention of lung cancer for Aboriginal and Torres Strait Islander people through talking about smoking cessation. Now I'll go over to Ray to explain who we are and where we're from.
We're from the Illawarra Aboriginal Medical Service. It's a community-controlled health service governed by a board of directors who are annually elected from the Aboriginal community. Membership boundaries extend from Helensburgh to Tarawa, and eligibility is Aboriginal and Torres Strait Islander people over 18 years of age.
This webinar came about, it's supported by the ACCHS, and it's come about because New South Wales Health has funded grants to Aboriginal community-controlled health services in New South Wales for purchase of nicotine replacement therapy. So this is a new program, and if you're working at an Aboriginal community-controlled health service, your management would have probably had correspondence about this funding for this. So this webinar is really designed to support health staff, including GPs, nurses, Aboriginal health workers, drug and alcohol workers, and other staff at AMSs to encourage safe use of nicotine replacement products, both in their clinics and also out in their communities as well. So let's have a talk about nicotine replacement therapies. I guess the benefit of nicotine replacement therapy is that you're getting nicotine, which is the addictive part of tobacco, without all the other harmful chemicals. When you're smoking a cigarette or a rollie, you're actually getting a whole lot of chemicals derived from a range of things, the pesticides that the tobacco is grown with, accelerants that make the cigarette burn faster. There's a whole range of chemicals that are quite dangerous to our lungs and can cause cancer and other health problems such as respiratory disease. So I guess the thing about NRT, you're not getting that damage to the airways. I worked for a long time up in the Northern Territory, and people, colleagues and people that I knew would actually use nicotine and chew tobacco. That's one form of tobacco where you use tobacco mixed with an ash from local trees, and you chew on it and then store it behind your ear for use later on, and you would actually get some nicotine going through your skin that way. The word in Creole around Catherine in the Northern Territory is actually mubud for that. In Central Australia, people for many years have used native tobaccos or pitchery, and that's also got a similar effect. So first of all, I guess the main thing to think about when we're giving out NRT is it's also important to give that support around it. And a lot of the support is actually what is the advice that's given by us as health professionals on quitting. We have to remember that many people, actually about 90% of smokers, will give up without help, but that nicotine replacement therapy can really increase the quit rates. But we still need to deliver all the advice. So this is the 5 A's. So we have to ask people about tobacco use and record their smoking status. And certainly in some of the electronic medical record system that we use, like Communicare, is actually with the OBS. So you can store them, record them as a smoker, ex-smoker, who never smoked, record the number of cigarettes per day if you can, previous quit attempts, and if they've got any smoking related disease. But I think certainly for your collection of data, you would need to record their smoking status. You can actually do this as part of their 715 health check as well. The next step is advise smokers to quit, and do it in a way that's strong, personalised, supportive and non-judgmental. You do not want to annoy people, you want to be supportive. So you might want to talk about their current illness and how that's caused by tobacco, and talk about the health benefits, that some of their health conditions will actually improve. Their chance of cancer will go down. They have many benefits. Good idea is to look at their willingness to quit, and I guess work with the people who are ready to quit now, or thinking about it. You'll always get a few hardcore smokers who don't want to talk about it. It's still worth mentioning something, but it's you need to catch them at the right time. Next thing is assist in a quit attempt, which is where the NRT and other medications come in, and then arrange follow-up. So it's quite critical, and we know there's a lot higher rates of success when people have follow-up from the health professionals. And I would actually arrange, I'd book a time to go and have a chat with them again, and I'll have a bit of a talk about how Quitline can help with that later on. Some of the 5 A's come from the RACGP, supporting smoking cessation guidelines, and I believe there is a new version being developed at the moment. This is a great document that many of you might have in your Aboriginal Community Controlled Health Services, and this is about medications to use for in Community Controlled Health Services, and it's a guide to NRT. So that's available online, as well as many people would have hard copy versions. So first thing is patches. You can get them over the counter, obviously on the PBS now. So they can be they're available on PBS on Close the Gap for Aboriginal and Torres Strait Islander people. You can get them, the scripts can be given by a GP or nurse practitioner. But actually with this new round of NRT, it can be given out by other health staff, and certainly they should have had some training on that. As mentioned, it's always good to deliver a brief intervention at the same time. A lot of the newer evidence is that even to start off with, you get better success rates when you use a patch and some other form of oral or intermittent nicotine replacement therapy. So there's actually not that many contraindications. Using patches is controversial in pregnancy, and I'll talk about that a bit later. Certainly, you would certainly need to monitor people if they've had recent cardiac disease. We do want people who've had heart conditions to quit smoking, but we do have to be careful of the use of patches. And of course, always record in the notes the type and amount of nicotine replacement therapy given. Many of you, all of you, would be using electronic medical record systems such as Communicare or Medical Director, or perhaps Best Practice. In your, you should record smoking status, but also record what type was given. As part of the program, services will have to report on how many different how the NRT was dispensed. Some side effects of patches: you can get bad dreams. For the people who get that, it's worth taking off before they go to bed. It's quite common to get a glue reaction, basically red skin where the glue was. You try different brands. You can use a weak steroid cream to dampen that down, and certainly keep rotating your patches to different parts of dry skin. If it's not sticky, you can use some tape. If you're getting a bit of nausea or dizziness, you just might need a lower dose, and they do come in lower doses, like a 21, a 14 and a 7 milligrams. They're pretty safe to use, but certainly you like I said, you've got to have care. So a course of about 6 to 10 weeks is normally recommended. You can actually use it younger. Our biggest problem is that people don't use it for long enough. It's more underdosing, that's a problem. So if they're getting it on a script, you can have the script has 1 month and then 2 repeats on, so that's for 3 months. You can get that twice during the year. And certainly with your funding from New South Wales Health, if someone is seeing a doctor and they can get free patches under CTG, you might want to think about them getting to get it on a script, because that means you've got more money to give to other people, but give patches to other people. In terms of dosing, basically if someone's craving a smoke, they might need a big dose. They might need some oral or inhaled NRT as well as a patch. Sometimes being irritable or stressed is a sign that they haven't got enough nicotine on board. Some people metabolize nicotine faster than others. There's a great webinar by Renee Batoon and Tim Senior, which is also on the RACGP website. And Renee Batoon talks about basically some people process nicotine faster through their body. If they're smoking very early, the time to first smoke is a good indicator of level of dependence. If someone has a smoke within the half an hour before they get up, they're probably going to need NRT and they're more dependent. Certainly, we used to see a lot of smokers who smoke 30 or 40 cigarettes a day. Now our heavy smokers are more 20 cigarettes a day. If people have more than 10 cigarettes a day, it's probably an indication they're more likely to be dependent. But I guess the main thing is don't give up. Most people need a number of attempts before they give up, but probably at least 6 to 10 attempts. If you're using a patch, peel off the paper, put it on clean, dry skin. After you shower in the morning is a good time. Press it down for 10 seconds. Remove at the end of the 24-hour period, and fold it over and dispose of safely, because you definitely don't want children or dogs eating the patch. Wash your hands, and then make sure you're rotating the site so you don't irritate the skin. Few myths about NRT. I'll let you have a read through those. It's basically NRT is just as bad for you as smokes, as they both have nicotine. It's not actually the nicotine. We are worried about the nicotine because it can cause blood pressure problems and addiction, but it's all the other chemicals that are in tobacco that are causing a lot of the damage. You can get hooked on NRT just like smokes. There is much less chance of that. It's the dose is actually much less, and it's much slower. So you get less of a hit from certainly from patches than you do from cigarettes. Nicotine causes cancer. It definitely doesn't cause cancer. Nicotine causes heart disease. It can put up your blood pressure a little bit, but overall smoking is much, much more dangerous for your heart and blood vessels than NRT. And again, we've got a little bit of information there about smoking and heart attack. It hasn't been really well evaluated. The research study is not really clear, but it's still better to stop smoking once and when you've got cardiac disease. A few of the different options. Gum. If you're having gum, I know you probably, if you're working AMS, you need to be able to tell people how to use the products. So certainly with the gum, chew it slowly. When you feel like a smoke, you feel a bit of a tingly feeling or peppery taste, and then basically park it in the side of your cheek. Move the gum around from time to time. Don't eat and drink. Don't swallow the gum, and throw it out after about half an hour. The limit's probably about 20 of the 2 milligrams or 10 of the 4 milligram pieces in a day. Certainly, it's reasonably common to get some bit of nausea or heartburn if you have too much. So with the lozenges, it should be sucked. Definitely don't chew them. Again, it will release too fast. Move it around from time to time. Again, don't eat or drink. Don't swallow it. And the limit is 15 lozenges in one day. The little tablets, mini tabs. You can place the tablet under your tongue until it melts. Again, don't swallow or suck it. You can actually drink with this one. Don't use them more than 40 in a day. But with all these oral forms, don't forget, some people will even vomit. You might have heartburn, some gut problems, sore mouth and throat, mouth ulcers. Hiccups are quite common, and coughing. Some people don't like the taste of them. There are different flavours of NRT as well, and it's worth getting people to try different flavours. Certainly, I had someone who liked the tropical flavour. Some people actually don't mind the peppery taste. Inhaler, especially for people who like have the hand to mouth action. The inhaler can be quite good for those people, and it's basically works is you put a cartridge in the inhaler and puff on it. It's lasts for about 20 minutes. and you can use between 6 and 12 cartridges a day for 12 weeks. Don't drink anything at the same time. The strips, I've had a few people recently who've really found the strips were really useful because they're quite fast acting. And you place the strip on the tongue and press your tongue to the roof of the mouth, and for about 3 minutes, don't chew or swallow, don't eat or drink. And basically, you can, with all of these things, this is a bit of a guide I've given here just to how to reduce it. You can actually reduce it over that 12-week period. With all of these, you can do a bit of a reduction plan over 2 to 3 months. The spray, again, I think people quite like the spray. It's quite fast acting. You do need to prime it. There's just a bit of a picture there about how to prime it. Point the spray nozzle towards your open mouth. Don't spray it on your lips. Allegedly, it tastes not great. Don't inhale it. And just don't swallow for a couple of minutes afterwards. And again, with all these methods, you use it when you're getting that craving for a smoke. Just a bit of a lot of the research now is saying the combination NRT is going to be more effective. So you can use a patch and say 6 bits of gum per day would be an example. So certainly you can try. So if you first quit attempt, it might be worth just trying one form. But if you have if that doesn't work, it's good to go to a combination therapy. You can start the very first go of using a patch and some other type of therapy as well. The patch kind of gives you the slow release in nicotine, and the intermittent NRT like gum or inhaler or spray will give you that little bit of a hit when you actually feel like a smoke. So, and there's a couple of ways you can do it as well. I'll talk about in a minute. This is a bit of a guide to the dosing. These are actually in the product information, and some of the, so it is worth reading that. And it does vary for different products, and there are a range of brands that produce all these different products. So it's actually worth checking on that. And again, I've talked about those with each of those different methods. Oh, go back to my. If anyone has any questions, please feel free to type them in, and we'll try to respond. Now, different ways to use your nicotine replacement therapy. There's various ways to use NRT, and there's no strict rules about this. The first thing is just to quit. So basically, you stop one day, you start the NRT on the same day. So and that's one way of doing it, and that does suit some people. People aren't so keen to do that. You can try starting a bit of NRT before you quit. Use a 21 milligram patch for about 2 weeks, and then you can stop smoking and stay on the patch. You know, often people won't feel like smoking as much because it does reduce the cravings in that 2 weeks. And then after that, you can actually add some intermittent NRT like gum or inhaler or spray, and if people still have the cravings. The other thing is to gradually cut down, and basically cut down the number of cigarettes while increasing the number of oral or spray NRT. So, and just do that gradually over 6 weeks, where the smokes go down and the NRT goes up. And you can still keep going with the NRT, like I said, for about 12 weeks, 10 to 12 weeks is good. Some people do wean down their NRT at the end. So, some of the recent research is that you don't really need to do that. Some people prefer to do that. They might, say if they're using intermittent NRT, they might reduce their gum or inhaler over the weeks after that. So certainly using the patches and other intermittent NRT is more effective. I'll talk a little bit about NRT in pregnancy. A little bit controversial about the use of NRT in pregnancy. Certainly we know that out of anything that you can do in antenatal care, getting people to quit smoking has the biggest benefit in terms of the health of the baby and in terms of perinatal mortality, a whole lot of things. So there's quitting at any stage of pregnancy is useful, but obviously earlier is ideal. But even if you quit in the last third of pregnancy, it's better than not quitting. Generally, we would say try cold turkey first, but if people do need NRT, it's good to try the intermittent sorts like gum or inhaler. And it's actually very similar levels of nicotine in people's blood as if they'd actually tried smoking, if they're actually smoking. So certainly for heavier smokers, they're more likely to need some NIT. You can't use varenicline or bupropion, the other medications in pregnancy. It's also important to be very generous in giving out NIT to partners and grandparents or anyone else living in the house as well. And a lot of the stop smoking programs for pregnancy do support family members. And I've just got a picture there from Quit for New Life. Got a question here about whether you can get a copy of the slides. They will be up on the ACCHS website, and the ACCHS has a great store of other talks that have been delivered by webinar in the past. So, okay, NIT for teenagers. Generally, we say you can use nicotine replacement therapy from 12 years of age. So we certainly do this in the later stage of our child health checks, and also from certainly with the adult health checks from 15. And we know that most smokers begin smoking when they're about 14, and certainly some kids start earlier. If kids are smoking regularly when they're 15 or 16, they can be quite dependent, and NIT can be very useful. Don't forget too, if people are smoking cannabis as well, they're often mixing tobacco with it, and NIT is really useful for cannabis smokers as well. Certainly with talking to adolescents, you can talk about smoking from 10 years of age. I think that's quite appropriate. Certainly we encourage a little bit of care, especially the younger age groups, and discuss it with a doctor. But especially for people as they approach adult size, it's safe to use. Just a little bit of a word about the other medications. Varenicline, it's a tablet that's available on script to stop smoking. It basically blocks the nicotine receptor. It's got quite a high quit rate, about 26% quit rate at 1 year, and it's even higher with NIT. You can get it on the script, and it is on CTG, but they do need to see the GP for that. A big question about whether it destabilises mental health. One thing we do know that giving up even without any NIT or stop smoking medication always destabilises mental health, and so it's worth monitoring people over that time. Again, common problems are nausea. You can give metoclopramide for that. It does normally settle, or you can stay on the lower dose for longer. It actually appears to be slightly more effective in women, but you can't use it in pregnancy. And again, the combination is more effective. So the general script is it starts with a low dose once a day. You need to get them to come back in 3 or 4 weeks for another script. It's an authority script. The next one's for 8 weeks, and you can actually even extend that. And you can actually smoke for the first couple of weeks while you're on it. And I've had a lot of really heavy smokers, even 40 a day, who've given up using varenicline. And they kind of describe it as it feels like they're smoking ash. They don't get the pleasure out of it because it's blocking those reward sense receptors in the brain. So you can use 1 course a year, but you can also use obviously use patches or use bupropion as well at different times. Bupropion is actually an antidepressant. It's also got a decent quit rate, again only on a script from through the GP. You do need to take care when combining with antidepressants because it is an antidepressant. One thing we watch out here is a slightly increased risk of seizure, particularly in those who've had epilepsy or head injury, but it can actually even occur in those who've never had seizures before. Again, can't be used in pregnancy or breastfeeding, and again, you can use it with patches as well. We always will, when we're talking about smoking, you will always get questions about electronic cigarettes. Now, these have been on the market, and there's been quite a lot of marketing around them over the last year or two. So we do get clients asking a lot of questions about these. So basically, these are different from the nicotine inhalers. These are the electronic cigarettes mimic the kind of act of smoking, and smokers that I've spoken to describe liking the kind of the suck action. So you get the nicotine without actually having the combustible, the smokable tobacco. They've meant to the design so they look like traditional cigarettes. They've got a cartridge in it that kind of basically atomizes the nicotine and a battery. again, people who like that hand-to-mouth action seem to like it, but I guess our main problem, it's not listed by the Therapeutic Goods Association. So it hasn't been assessed in the same way that the other NRT that we've talked about has been assessed. We don't really know where it's made, or what the safety levels are in the companies where it's made. So we don't know. So at the moment, the guidelines are not to recommend this to patients. And certainly remain neutral on it. But at the same time, we do acknowledge there are smokers who use it. In 2013, about 14.8% of smokers aged 14 or older had used the electronic cigarette. So I'm sure you'll get questions about that. Don't forget to support services when you're giving support to people who are giving up smoking. Quitline's a really obvious one. That's really been, that will be accessible to you all. It's Quitline is the numbers on the back of the cigarette pack. It's the cost of local call. It's available 24 hours a day. One thing I found really useful is the fax back service. So you can actually just download the form from their website. And some people, you can tell people to, call the Quitline for the callback service. And if they call it up, they can actually get support from a worker there. There's an Aboriginal worker there who will call back and give support people, and actually follow up people over the next number of weeks. I tend to find people, they often don't get around to doing it. If you do the fax back service, the Quitline will give them a call, and then people can decide what they want to do. And I have had people then who've gone on to have more follow-up calls. So, and that has really helped. Don't forget too, with the Quitline, if you're trying to get resources, now that you've got all that NRT at your service, that there's, you can call the Quitline to order up QuitBooks and stickers and a range of products to help support people when they're trying to give up smoking. So you can use it for that as well. Certainly, if you need more support at your AMS, some AMSs have developed quit groups. Certainly, you can refer people to drug and alcohol workers who might have more time than say rushed other workers in the clinic. There's other support that you can organise in your service, and you need to have a think about what you are going to do in your own service now. That's just a slide from the National Tobacco Campaign, and it's really getting people to think about why they're quitting, what are the reasons that they're actually quitting for. Okay, now in terms of you out there at your Aboriginal Medical Service, for the people who are organising these in each service, the funding would be through your management, but then you need to work out how you're going to order the NRT. So it can be ordered from a variety of sources like private pharmacies or wholesalers, and I guess the prices vary a lot. But however, you might want to make sure that the expiry dates are going to cover the period that you're trying to give the NRT out. So they might give you a good price if it expires soon. So if you're going to have a really big event and you know you're going to give a whole lot out really quickly, that might be fine. But if you're going to stock it in the clinic, you might find that you're not getting through your supply. Now that the funding has arrived, you might actually need to do several orders through the year. So, and then you can assess how you're going. It's actually good to get a range of products so that different people can try different products. And like I said before, don't forget that smokers can get NRT. If they're seeing the doctor, they can get a script for the NRT, and that may means your other funding will stretch further. But other staff, like health workers or Aboriginal or nurses, can dispense patches without seeing a GP, seeing the client. So you need to keep a good stock of patches and other NRT. Now, the way you can fund that is certainly during health checks. It's a really great time to give people advice about smoking. We certainly record their smoking status then, but it's a good time to deliver a brief intervention and to give out some NRT at that point. I think staff should definitely be trained to use it. If there's any concerns, I guess people like pregnant women or adolescents, is good to ask the GP for support. Certainly with people with serious medical problems, it might be worth running it by. In terms of the And don't forget when you're giving advice that it is covered by the normal Medicare that you're using if you're seeing them as part of a medical consult. In some services, I believe that they've used the 10987 Medicare item, which by an Aboriginal health practitioner, to actually run quick groups, or you can use the follow-up appointments after a health check or a chronic disease care plan to give advice and follow up people. And that could be used for giving out NRT as well. I mean, other services might, certainly our service is planning some outreach programs, and different services might consider support groups in other exercise groups or youth groups or men's group. I'll get Ray to talk about our outreach soon. So just one of the things that New South Wales Health will be getting services to do is to collect data on their use of the NRT. Now, services are already required to collect smoking status, and that can be done in a program like Communicare, and certainly at the time of health checks, as I mentioned. It's also good to work out how you're going to record giving advice about tobacco. So it might be worth to check through your program and check how you're going to do that. It might mean you record a clinical item of smoking brief intervention, but you've also got to work out a way for your organisation to collect data on how much you give out. In some services, this could be an exercise book next to the NRT store, but you need to be able to deliver that information back to the funding body. So certainly when we're getting data, it helps us to plan future programs as well. It basically helps us to run programs. If we think about running a quick group and coordinate the lists of clients, it basically is for monitoring, to feed back to our community as well as New South Wales Health. And we want to know if they're actually working, and we should be able to find out from our smoking status whether it's actually worked. You can also pull up data on prescribed patches or varenicline or bupropion from your electronic software as well. That's quite easy to do. I guess the main thing is to work in each organisation. You've got to work out how you're going to record that so that we know that the NRT is being used well. Just reflecting back on the new National Aboriginal Community Controlled Health Organisation, the NACCHO National Guide to Preventive Health Assessment for Aboriginal and Torres Strait Islander people. On smoking, there, just a bit of a reminder to how often you should talk about smoking. And we know that talking about smoking is a very major part of preventing lung cancer. And so the recommendation there is asking all people aged over 10 if they smoke tobacco. Do it every time you see them or as part of a health check. Certainly, we talk about asking people who are current smokers. We should ask them every time about their smoking and whether they're ready to quit this time, and think about their level of dependence so we can guide what we do. Certainly, again, the 5 A's: ask, assess, advise, assist, and arrange follow-up visit. So, certainly for people who are aged over 18, you can use NRT, varenicline, and bupropion, and the adolescents, as I said, can use the NRT as well, and do that at every visit. Same thing for pregnant women. Give advice at every antenatal visit, and certainly think about other programs in your service. Think about how you record smoking, and think about your health promotion materials, whether you need some more posters or displays, more pamphlets, some no smoking stickers for people to take home, and you might want to think about your smoke-free rules at the health service. And certainly on the AHMRC website, there's some materials there, a manual that can help services guide their policy around smoking in their service. Certainly the other things is we now don't recommend CT for screening for or X-ray for screening for people at high risk of lung cancer. Well, that may change. There is research going around that. But for anyone with lung conditions, giving up smoking, this applies to any kind of lung condition like recurrent pneumonia, COPD. It means giving advice every time to those people, and certainly as part of child health checks as well to prevent exposure to secondhand smoke. So again, that should be part of our routine delivery of care as part of child health checks and adult health checks. Okay, we might go from the, we've got a question here actually. Is it safe to use NRT post-surgery or heart attack? I'll have a talk about surgery first. There's quite good evidence that giving up smoking before surgery does improve outcomes of many major surgeries, including it gives up, even giving up smoking in the short period before surgery can improve healing times and reduce clots. So it does. So it's very important around that time, and some surgeons won't even operate on people if they continue to smoke. Certainly after surgery, hospitals will provide NRT, to stop cravings while people are in hospital. With cardiac disease, again, as I mentioned before, the research around this is not really clear. Certainly after 4 weeks, there's good outcomes from NRT, but with in the first period after a heart attack, it does mean going with care. You know, people have got to be very closely monitored. As I said, it hasn't been fully researched, but it appears to be beneficial at this stage. And again, there are studies being planned on this. So, okay, we're going to go now to a bit of a Q&A and over to Ray. Do you want to introduce yourself, Ray?
I'm Ray Collins. I'm a 48-year-old Aboriginal man. I've been smoking for 25 years. Just recently started the ACCHS, and I thought it was time to give up the smokes. I've had a couple of clients come in asking to stop smoking, and my biggest thing was that if I don't do the walk and do the talk, I'm no good to them. So I thought to myself, I'm going to give up the smokes once and for all. Some of the, mainly when you talk about, you're getting into you talk about the health and the generational part of my family where I lost both parents to smoking, lung cancer. So I was getting to that time. I wish I'd have done it earlier, but that's the main reason is basically for health concerns and for my children, and be a good role model for the family.
So Ray, just tell me a little bit about when you started smoking. What were the things that made you start smoking? Well,
looking back on it, was parents smoking in the house, smoking in the car. So I didn't pick them up till I was 23, but now I look back on it, it was a continuation of just secondhand smoke that I inherited the smoking.
And now, when you made your first attempt at giving up smoking, tell me what you did then.
I went cold turkey, and at first I used a bit of Champex, and then I went cold turkey when I was 40, and I gave them up for 3 years, and until I met up with the mob one day at a funeral, and then picked them back up again.
I guess it's great to remember that most people have to give up many times, but each time gives them the experience in how to approach it differently the next time. So what about this time? What were the reasons for quitting this time?
Well, health concerns and being a role model for the Aboriginal people around the health and medical service. Like, as I said, I get clients that come in, and I was counselling them on smoking 5 A's, and then at the same time I was running around having a smoke when they'd left. So to me, that was just cheating and lying to them and lying to myself. So with help of the ACCHS staff and other people that I've able to get on the NRT products and give it a good nudge this time.
So when you made previous quit attempts, how big a factor was the cost of buying smokes in your decision?
Well, that's funny, we were talking about that the other day. When it come around the time to buying the NRT, discussing about giving up the smokes, was the cost of NRT products were a major burden to me. So when I discussed with the health workers, I said, look, they said that they'd help me out with a few NRT products for a couple of weeks. I said, well, that's probably, in my mind, that wasn't good enough, that I needed a full program of 8 to 10 weeks. So we come to a agreement that I'd be supported for 8 to 10 weeks. And then now I'm into my 10th day, and I haven't smoked now for 5 days.
Tell me a little bit about how you're using the NRT this time.
Well, I get up in the morning and I put my patch on. The first couple of days I was patch, coffee, cigarette, the normal, and throughout the day using the inhaler and gum. After the 4th day, I worked on some triggers and realised that the coffee had to go. And that slowly decreased the craving for the cigarette. And within the first 7 days, I'd stopped smoking. But the big help for me was the inhaler, the mimicking of having the cigarette. But that's reduced now to I use it probably 3 times a day. The patch is very important, and a bit of gum during the day. So out of the 4 milligram gum, I bite it in half and have 2 lots over half an hour.
Okay, great. Now you were saying that your wife's been using the Nicotine, the Champix. How's she found that?
Yeah, good. She we come in agreement that we were giving up at the same day, and since I've learned a bit about the NRT products, she now uses that and a patch and a little bit of gum during the day just to fight off those urges. But she's it's been working very well for her. It didn't work for me, that medication, but it works very good for her. But she since we've given up and we've got a few more dollars in our pocket, we're actually able to attend the gym now. So I've seen a major difference with her. She's going there twice a week, where I couldn't even get her to look at the gym door before.
Oh no, that's great. Now, what kind of things do you notice now that you're a non-smoker?
Definitely the smell of smoke. I can notice that. I hopped in my sister's car the other day, drove it to work, and she puts her cigarettes out in the ashtray. So first thing I could smell was the ashtray, and I had to pull that over and empty that out. Taste, I've got my taste buds back, and I'm starting to like variation of different foods again now. When I smoked, I was smoking coffee, and I had that bad taste in my tongue all the time. So and even when I had the NRT products with the mint gum, I can really taste the mint more than the nicotine.
Oh, great.
So so I am, and smell. You definitely get the smell, and the good breathing too.
Hey, now, Ray, I might just have a bit of a chat, because most of you out in Aboriginal community controlled health services will be thinking about what kind of programs you can design to support giving out the NRT. Do you want to just tell us a little bit about the men's group and what you're planning there?
Yeah, we're the Illawarra Aboriginal Medical Service. I've been talking to Shane Venables, the Aboriginal men's health worker there, and we've come up with the funding with the NRT products. So we're going to be delivering brief intervention programs with the Aboriginal men at the Illawarra Aboriginal Men's Group, which will be involved in yarning and getting involved in the NRT products, and with myself just starting out and using the products is getting past that myth of people not believing in them and getting them to understand they do work and how they work. I didn't understand that how to use the gum properly, to spray properly, but getting them to understand that they work is going to be a huge step. And in saying that, we're talking about doing external visits to the clients. So we're going to do a progress over 4 to 6 weeks, is actually going out, seeing if they're using their products. So like it's not sitting in the drawer and assist and advise and support to the men.
Great. And I think in different AMSs, you might have a variety of ways that you can use NRT in programs. Certainly you can use it in seeing patients in the clinic normally. You might have diabetes groups or mental health groups, and you might find there's clients there that would like some specialised support about smoking and be supported in using NRT. A lot of the antenatal programs already have access to some NRT. Certainly, for family members, that's very important. So it's important for us to think about that. We also actually offer it to parents when they come in with their children for child health checks. So you might even find it's got a role in your child health programs as well. But certainly, it's great to go out to do some outreach. I know in other communities there have been quit smoking programs, for example, for sporting teams or for workplaces that request support where they have a lot of smokers there. So you need to tailor that to your community and work out appropriately how to use the NRT and also reach people who aren't coming into the AMS, especially young, well people. They may not be attending the AMS because they're working. So it's good to think of ways to reach out to those people too.
And I'd also like to say I get support too from the Corey Quit line. They actually ring me twice a week, which, you know what, at first I was looking at the number going, I know I don't want to talk to you. And then I started answering it, and I thought, you know, there'd be a non-Indigenous person there, but it's actually, she lives up at Alice Springs, and she phones me twice a week to see how I'm going, which is a great support knowing that someone else is there on the other end of the line, and she gives me great tips too.
And that's right, it's great to tell people about the Quit line and, like I said, to do a fax referral to them if you think those people need follow-up, if you're not able to do it yourself. We've just got one more question coming in. Is it worth doing a spirometry test on smokers, and is it Medicare claimable? Certainly the research around COPD and airways disease, like emphysema in smokers, is that about 100% of smokers have some degree of emphysema if they've smoked for 20 years. So if you smoked from when you're 15 to 35, you're going to have some emphysema, and spirometry is Medicare claimable. The other thing that a lot of AMSs might use, especially in their quit groups, is a smokalyzer. That's a machine that can look at the level of carbon monoxide in the blood, and that can be quite a good guide for giving people a feedback about how they're going with their smoking. I actually find just asking people how much they're smoking is quite effective as well, but many of you will have that, and that can be quite a good tool to use at events or in your quit groups if that's what you decide to run. Just a reminder too that the slides today will be up on the ACCHS website, and there's a great range of talks there, other talks as well for people to use. If anyone would like to contact us for more information, I've just got our details of the Aboriginal Medical Service there, of our 2 clinics, and my email address there. Certainly there's some great resources around too. The National Tobacco Campaign has some great resources. The Quit Coach is excellent. The ACCHS has produced guidelines for cessation, and they are being updated at the moment. And also on specific products, the NPS has excellent fact sheets that can be printed out to give to patients when they're using a specific brand named product. And of course, don't forget there's product information with all the products when you purchase them as well. Thank you again for attending today, and good luck with your smoking cessation programs.